afternoon, everyone. I'm Maureen Dobbins, and I'm happy to be here today to talk to you about childhood obesity prevention, a webinar being hosted by healthevidence.ca. The first thing I'd just like to do is encourage all of you to fill out the 2 polling questions that are currently open. The first one asks what has been your experience in finding and using evidence related to childhood obesity prevention, and the second one, how do you use research evidence to inform your practice? If you could just fill those out. That's just some information we're trying to track. We will also be asking you questions as we go. And I'll just take a moment now to just make sure everyone can hear me okay. If you can't, if you can let us know via the chat, and we have people on board that can provide you with some information if you're having some difficulty. So I just want to introduce to you, show you who we are. This is the Health Evidence team, and really the hosting of these webinars is a team effort in terms of many of us around the table to be answering, looking up information as you ask questions, and keeping track of everything that's going on. And so we're all very pleased to have you joining us today. So just quickly, what is healthevidence.ca? So for those of you who perhaps aren't familiar with who we are, healthevidence.ca is a repository of all systematic reviews evaluating any public health intervention that have been published since 1995, and we're accumulating all of those in one place so that it is a one-stop shop for effectiveness evidence at the review level for public health around the world, with the hope of facilitating easier integration of evidence into public health decision-making. So why use healthevidence.ca? We use Health Evidence. With healthevidence.ca was created to save time. We've learned over many years of interacting with frontline health professionals that looking for systematic reviews related to public health interventions in, for example, large databases like Medline is really like looking for a needle in a haystack, and that there are better ways in which public health can use their time than actually spending time looking for the evidence. So putting it all in one place, everything in Health Evidence is relevant to public health, and at any given time, we are only behind publication by approximately 2 months. We use a very transparent process so that you can go online and see how we decide what reviews are relevant to healthevidence.ca, how we assess those reviews for methodological quality, how we assign keywords to those. All of those tools are accessible to you in the Judge for Yourself section that you can click on the website. As well, we know that providing the evidence and even summarizing them as the webinar is doing today is only part of the process of evidence-informed decision-making, and that there are also additional efforts that are required to really put this evidence into practice. And so at Health Evidence, we've been creating other services and products to support public health professionals in engaging in the process of EIDM, as we call it, and those are accessible to you. We've also been engaging in evaluating many of those KT strategies, knowledge translation strategies, over the years through funded research, primarily through Canadian Institutes of Health Research. And of course, we're trying to make this all as easy to use as possible, and we encourage your feedback from all over the world in terms of how we can continue to improve this resource for you. So we're going to do the poll. We have another polling question for you right now, and I am just interested to know where everyone is from, and you're doing it. Right now we see that many of you are from Ontario. I can see that. You can't see that. We're also seeing that we have representation from really across the country, and also at least one person from the United States. So welcome to everyone. So this webinar is brought to you today by a project that's been funded by CIHR. This is our project number listed here, and this was funded through the Knowledge Translation Supplement competition, and we're grateful to have these resources to be able to bring webinars to you. There will be 8 topics over the coming year, and what we are seeing is a large number of subscribers to various topics, and so as has happened for this one, occasionally we'll be holding them more than once to ensure that we have spots for everyone who wants to join to be able to join in. And we're also, of course, wanting to do a little bit of evaluation of that, and so we'll be, I'll be talking to you a little bit more at the end of the presentation about a short evaluation survey we will ask you to fill out. So today we are actually talking about a new review, relatively recent review that was published in December of 2011 by Elizabeth Waters et al., a Cochrane review on the interventions for preventing obesity in children. And this is an update to a previous review completed by Somerville in 2005, I believe. And believe it or not, I was just in email communication with Liz Waters, who's in Australia, earlier this week, and they've already started working on the update, which will likely be available, I would assume, sometime in the next 12 to 18 months. So I'll just take a moment there to see if there are any questions from anyone. And I'm not seeing that there are any questions, and so why don't we just jump right into it. So this summary statement, let's just talk about PICO for a moment. Who is familiar with, prior to today's webinar, have you heard of PICO? If you could just fill that out. And as you're doing that, we're seeing that it's fairly even, and that about half of you have and half of you haven't. So very briefly on what you're seeing here in front of you, PICO is a way for us to really think about what is the question that this review is addressing. And the P stands for the population of interest. I is the intervention that we're interested in learning something about. C is what we're comparing the intervention to, and O are the outcomes that we're interested in. And so for this particular review, we can see that the population are children and adolescents between the ages of 0 and 18 years that were further subdivided into 3 subgroups, 0 to 5, 6 to 12, and 13 to 18. All of the interventions are relevant for obesity prevention, were conducted in various settings, including the community, school, home, daycare, and preschool settings, and they were focused on promoting healthy eating, physical activity, and social support. This was compared to whatever would be considered usual care in any of these settings, which in some instances maybe wasn't very much intervention, and others would have been, for example, what would have been the typical physical activity program in a school. And the outcome that we are focusing on today in this webinar is body mass index, or BMI. Now, it's important to state, and for you to know, that this review actually covers a great many outcomes, one of which is BMI. Their primary outcome for this review was BMI, but they also focus in the review. If you were to go and download the full text, you will see some discussion around physical activity rates, fruit and vegetable consumption, percentage body fat. So there are many other outcomes, but the main outcome that we'll focus on our discussions today is body mass index. Right at the bottom of your slide there, you're going to see quality rating 9 and in parentheses strong. So this is a very well done systematic review. At healthevidence.ca, we use accepted criterion to assess the quality of the reviews, and the highest possible score a review can achieve is a 10. So this review it has been rated very well, as we would expect from any Cochrane review. However, it is important to point out that while the methods of this review are very strong, the literature upon which this review is based, so the primary studies, actually has a number of limitations in it. So that body of literature as assessed by the reviewers, is of a low to moderate quality. So there's a number of limitations within that. So let's just start talking about, I like to start with what are the overall findings and considerable overall considerations. So what the results of this review illustrate is that there was a statistically significant overall positive effect for BMI in the meta-analysis results. However, while there was an overall statistically significant positive effect, when this was assessed by the 3 subgroup population, so by age, we only see statistically significant effects for children between the ages of 6 and 12 years old. For children 0 to 5, there definitely was a positive trend, or a trend towards a positive effect. However, the confidence interval did not achieve statistical significance. And similarly, for adolescents aged 13 to 18, we also did not see statistical significance there, although there was a trend towards a positive effect. Furthermore, when we think about what were the interventions that seemed to be most effective, a combination of physical activity and nutrition interventions combined resulted in the greatest impact among the 6 to 12-year-olds. So much better for these 2 interventions to be provided together than alone. Physical activity on its own did result in statistically significant positive effect, but was approaching the line of no difference, and I'll go over that in further detail in a moment. The education setting alone also was associated with statistically significant reductions in BMI, as opposed to interventions that occurred in multiple settings or not at all in the school setting. And quite interestingly, the results of this meta-analysis also showed that interventions of both a short and or long duration had similar results in terms of significant effects. So for example, interventions that were less than 12 months had a similar level of effectiveness as those that were longer than 12 months. The other analysis conducted in this review was to see whether or not the results differed by whether or not it was a randomized controlled trial or not a randomized controlled trial. So we still had control groups, just not randomly allocated, and the results were consistent whether a randomized controlled trial was conducted or not. Just thinking here for a couple of seconds, just going back here for a moment. One other thing that's really important to point out here is, and the authors definitely make this point strongly in their review, is that there is a fair amount of variation across the studies. So from study to study, the results varied a fair amount. This was not explained by research design, i.e. randomization, or how long the intervention went for, or where the intervention was implemented. So we need to have caution in how we interpret these results, because we don't know what's driving those differences across studies. So those are the overall findings of this review. For those of you who've had the chance to already look at this review, I've noted that it's actually 212 pages long. So this is really the Coles Notes perspective in terms of what those main overall findings are. So let's now think about what the general implications are for these findings. Basically, the evidence at this point support that public health should promote or support or implement strategies to prevent obesity, particularly in the 6 to 12-year-old. That these interventions should be done in the school. That's where our evidence is suggesting they're most effective. That it needs to be focused in a combined way on healthy eating and physical activity, and that various durations of interventions can be effective. That's the positive side of things. Where we have more work to do, as the evidence illustrates, is that we don't yet know what seems to be effective for children under 5 and for adolescents 13 to 18. So more work needs to be done. And I hate to say that in terms of more research needs to be done, but I think what we need now is innovative ideas on additional strategies that we can be evaluating for these other age groups. As well, the long-term impact of these interventions remains unclear. And so while we're really excited and happy about the finding around a reduced BMI in this population, and particularly amongst non-overweight children, that if that were to be maintained into adulthood, then we have some excellent population-wide outcomes occurring there that have implications for chronic diseases. However, the evidence isn't clear at this point whether or not these gains can be sustained in the long term without ongoing intervention, and so we need more work on that into the future. So if we just break the evidence down now to look at it a little bit more closely. So I gave you the overall findings. Let's look at things a little bit more closely and look at some of the numbers. So what we have here in front of you is when we looked at all, when Waters et al. Looked at all of the studies, of which there were 37 of them included in this meta-analysis, the overall impact in BMI across all age categories showed a minus 0.15 unit of BMI reduction in the intervention group in comparison to the control group, and that the 95% confidence interval ranged from minus 0.21 of a unit to minus 0.09. So if we're thinking that among 6 to 12-year-olds, an average BMI might be somewhere around 16 or 16.5, we're talking about a reduction of 0.15 with that range, 0.21 to 0.09. When we look at just 6 to 12-year-olds, we see a similar story there. We see the same overall effect size, which is the minus 0.15, the 95% confidence interval ranging from minus 0.23 to minus 0.08. So let's just take a moment to talk about what this 95% confidence interval is. Why is this so important? Why aren't we just worried about the minus 0.15? So the 95% confidence interval tells us that 95 times out of 100, the true effect of these obesity prevention interventions on BMI will range from minus 0.21 to minus 0.09. So it gives us a range where we can be 95% confident this is where the true effect lies. And what we're wanting to make sure here is that this confidence interval would not be touching the line of no effect. And I have a diagram I'll show you in a moment to reflect that a bit better. What we saw, and I'm going to show you in a diagram, but didn't put the numbers here, is that for both children 0 to 5 and adolescents 13 to 18, the confidence interval did cross the line of no effect and therefore is not a statistically significant finding, even though the point estimate was a fairly good number, was a low number, around 0.25, but the confidence interval wasn't statistically significant, and that is what gives us cause for concern. So I've now put in front of you the results of the meta-analysis. It's a little bit small, and all I really want you to look at are the lines and the diamonds. So if you can't read the numbers, that's actually even better, because I don't really need you to be looking at the numbers per se. So this is from the Cochrane review, the Waters et al. Cochrane review, meta-analysis that looks at what the impact of the obesity prevention interventions were on children 0 to 5 on BMI. And what we can see here is the vertical line. So if you're looking underneath the standard mean difference, and then it has the random effects model, 95% confidence interval. It's on the right-hand side of this graph. We have a vertical line. That's what we would call our line of no effect. And the horizontal lines are the confidence intervals for each of those studies that were included in that meta-analysis. So we're just showing that to you right now. And what you can see is for any of those lines that actually intersect with the line of no difference, that tells us that there was not a statistically significant difference between the intervention and control group on BMI. And one of the things that we notice when we look at this is that there are only 2 studies for which the confidence interval does not intersect the line of no difference. So we're just showing you those 2 right now. The other thing to point out with this graph, for those of you that are unfamiliar with forest plots, or if this isn't your favorite type of graph to be looking at, is in this instance, we want to see lowered BMI. And so a positive effect of the intervention would have our confidence interval, so our horizontal line, on the left-hand side of the line of no difference. If our confidence interval was completely on the right-hand side of our line of no difference, that would actually be saying that the intervention group was worse off or had a higher BMI than the control group, or in other words, it makes it appear that the intervention was in some way harming our students. So here we see a number of studies that are reporting no effect, so no difference between the intervention and control group, and we have 2 studies reporting, and one in particular, fairly sizable, statistically significant positive effect. The black diamond at the bottom is the synthesis, for lack of a better term, averaging. It's not really quite averaging, but it's the averaging out of all of those results to come up with an overall effect size. And if you were to take the ends, look at the either end of the diamond, that becomes our confidence interval when we add up all of those studies. So we see that what we're looking for here is that it's made our overall confidence interval much smaller. That's what we want to be doing with a meta-analysis, is getting a more precise estimate of effect and range for which the true results exist. The other thing, and I'm just going to ask a question here to Heather, are we able to remove this second red dot? I don't know if we can do that, but I'm going to try an eraser here. There we go. And so what we see here is that upper end of the confidence interval touches the line of no effect. So that's where we get this positive trend in lowered BMI, but the upper end of the confidence interval touches the line of no effect, which now means we do not have a statistically significant finding. So we're just going to move on. I'm going to show you another one just to give you a bit more experience of looking at these. So this is a much busier meta-analysis for us plot. This is for the overall results for children 6 to 12 years old. And we have all of our confidence intervals listed here. There were, I believe, 31 studies included in this meta-analysis for this age group. And all I want you to focus on here is you can see right at the very bottom that our diamond is very, very narrow, and it does not touch the line of no effect. So we can see that there, which now can tell us we have a statistically significant finding. This is also important to be able to interpret these types of graphs because by including this graph like this and giving us the confidence intervals, we might not see p-value. So that p-value that's looking at telling us whether or not we have statistical significance. So p is less than 0.05 or p is less than 0.01. We wouldn't necessarily see that in a graph like this because our confidence interval, by not touching the line of no effect, is in fact telling us whether or not we have statistical significance. More and more results are being reported this way, and so it's important to be able to interpret statistical significance when our p-values aren't there. So what we can see here, and this is a point for discussion I would like us to get to a little bit later on in the webinar, is this also allows us to see just how far away the upper limit of that confidence interval is from the line of no effect. So while we have statistical significance, it's also important to think about, is this a big enough reduction in BMI to warrant the resources needed to implement this intervention? So we have statistical significance. Now we need to be thinking about clinical significance. So I'm talking here about the diamond overall is giving us our sense. And we can see, I mean, this is a bit of a scale issue here and a little bit hard to see. I just wanted to get the whole meta-analysis on the graph to be able to show it to you. But we could have, I'm sure, a very healthy debate about whether or not this is a big enough reduction in BMI to warrant the resource. And really our job here at Health Evidence to show you the evidence, to help you understand what the evidence means, and I would suspect that many of you might make different decisions on what to do with that evidence in terms of your programming based on what the needs are in your community. And then finally here, just to show you the overall meta-analysis results for adolescents 13 to 18. So again, here we have a much smaller number of studies. I believe there were 8. And again, we see our diamond touches the line of no effect, just barely. It's just going over that line, which again is telling us there was a positive trend, but not statistically significant. And I'm just going to show you now that bottom diamond in case anyone's eye has wandered down there. This was the overall diamond that's adding up the results from the 0 to 5, the 6 to 12, and the 13 to 18. So it was really important in this meta-analysis that the authors did the subgroup analysis, because we might have erroneously made the assumption if they had just done overall that these interventions were effective for all age groups, when in fact they aren't, and there's a bit more work to be done. So what does this mean for implications for policy and practice? And also, I'm very wanting to hear your thoughts on that as we go through the webinar. But certainly at this point, it appears that the evidence would support obesity prevention in education settings, and that should be focused on a combination of interventions looking at behaviors around physical activity and lifestyle, but that we need to continue to investigate strategies for other ages. The reviewers also looked at the type of intervention, and what we can see here again is when there was physical activity and nutrition interventions combined, and this is all again what the impact was on BMI for children aged 6 to 12. And here we see that we saw a reduction of -0.18 units of BMI with a range from -0.27 to -0.09. Physical activity alone did also achieve statistical significance, with the effect size being -0.11 BMI units. But as you can see, the confidence interval went from -0.19 to -0.02, which is just shy of the line of no difference. So while it is statistically significant, it's very close to not being different from intervention to control group. So something we just need to consider. And then I haven't included the number here, of course it's in the review, when nutrition was implemented alone, so healthy eating interventions, the finding was not statistically significant on BMI. And so what does this mean for us, again, in terms of implications? Well, we're suggesting that public health needs to support interventions to change physical activity and healthy eating behaviors in 6 to 12-year-olds, that increased sessions of physical activity during each school day for children is important, and also what goes along with this is supporting and creating an environment and a culture that facilitates children to be more active and to make healthier eating choices every day at school are important components of an effective obesity prevention strategy. The next area that they looked at was the setting. So where are these interventions occurring, and do we know anything about in which instances they're most effective? So interestingly enough, the meta-analysis identified that when the education setting was the only place in which the interventions were implemented, that is when we had a statistically significant effect in our 6 to 12-year-olds. And we see here a -0.14 reduction in BMI units. That range similar to what we saw overall in BMI. Those are -0.21 to -0.08. And we did not, I keep thinking I've done this review, Waters et al. Did not find a statistically significant finding when the interventions were implemented in both the education and other settings, or when it occurred in a non-education setting alone. Okay. And I'll come to your question in just a moment. I just want to finish off one point here. What was also seen in this review, and very interestingly so, was that in children less than 5 years of age, there was a statistically significant effect on BMI in those interventions done in non-education settings. And that does make intuitive sense in terms of most children aren't in the school setting there, and so this is happening in home, daycare setting, in other types of settings. So that is important to note there. So I'm just seeing, so the question here is, did the authors exclude clinical settings? Thank you, that's a great question. What is worded in the review is that interventions occurred, and I'm just quickly referring to that. The settings included the community school and out-of-school hours care, home, child care, and preschool, nursery, kindergarten were eligible. So it would appear that if it was solely happening in a clinical setting, that it likely was excluded. Yeah, so I will just go over the last comment again from the slide. What was also found among 0 to 5-year-olds was interventions implemented in the non-education settings did lead to a statistically significant reduction in BMI. So that's different for example, children from 6 to 12, interventions were shown to be effective when they were in the education setting only, not happening outside of the school setting. But in younger children, the statistical significant effect is observed outside of school, like, for example, a preschool setting. Okay, so there's an additional question that's there. What was the diversity mix in this study? And so if someone is just looking into that for me right now, we'll come back to that momentarily as soon as I have an answer for you. Okay, so let's keep going. So what are the implications for practice and policy with respect to the intervention setting? So definitely what we see a support in the evidence for is the development of curriculum that includes both content related to healthy eating and physical activity, as well as the inclusion of more opportunity for children to be physically active throughout the school day, so increased sessions of physical activity, an improvement of the healthy foods that are available to children in schools throughout the day, as well as public health should actively engage in the training and capacity development of teachers and staff in order to be able to provide health promotion to students. And then with respect to, and this is focused on that 6 to 12-year-old group, and then for the very youngest of children, public health, there's evidence to support public health engaging with the parents of young children to help support healthier eating, more active lifestyle, so more active living, as well as reducing sedentary behavior. So that can be interaction in the home, with parents and other types of community settings in order to help parents change what they do with their young children. So I'm just coming back to the question that was raised about the diversity mix in this study. I'm just going to read, and this is actually on page 33 of the review itself. It says, this review included studies from high-income countries as well as lower, middle, and upper middle-income countries, with 5 studies conducted in countries within the latter 2 groupings, so 5 studies from the lower middle and upper middle countries. What we also know is that a total of 19 studies specifically reported incorporating strategies to target socioeconomic and or cultural diversity and disadvantaged. A number of the studies that were conducted in the U.S. were focused on African American, Latino populations. However, I believe that there was only one study that actually did analysis according to the level of disadvantaged in the school. So they labeled the schools as underprivileged or not, and so only one study actually focused on that. Because there was only one study that did that, I didn't pull that out to specifically speak about in this overall summary of the results for today. So let's talk a little bit about intervention length. So the reviewers also wondered if the length of the intervention would have a significant impact on BMI. And to be included in this review, the intervention had to last for at least 12 weeks. So any intervention that was offered for less than 12 weeks was excluded. But what they did divide out was programs that were less than 12 months and compare those to programs that were greater than 12 months. Or I shouldn't really say compared, but they offered results, meta-analysis results. And really across those 2 different groupings, we have very similar effect sizes and confidence intervals. So basically the key finding there is there isn't a huge difference in the overall findings of the shorter duration versus longer duration. And our implication for policy and practice is that the tailoring of that length of the intervention should be consistent with what the needs are of the specific education setting. So I don't think that we can, it's necessarily crucial to tell a school that the intervention needs to be a certain length, because that is unclear at this point. And that if they're willing to work with different types of parameters, something shorter than 12 months is more effective for them, will fit better, then I think we need to work with schools around what is most useful for them. So the last area of meta-analysis that was conducted in this review was to determine whether or not the randomized control trials had a different result from the non-randomized control trials. And here what we're talking about is all of the studies included in this review included a design that had one group receiving the intervention and another group that was not. And in a number of those studies, that was randomly allocated, and in others it was arbitrarily determined due to different factors. So overall, randomization was not a key influence in whether or not statistically significant reductions in BMI were reported. So very similar results in BMI were reported whether it was in a randomized control trial or not, which is very useful information, a really good analysis to have conducted in this particular setting. Because if we only had a positive effect, statistically positive effect for our non-randomized control trials, and we didn't see that when we had an RCT, then we would be a little bit less sure of how much confidence we would put in the non-RCT results. But the fact that there's consistency across designs adds to the body of knowledge and adds to our confidence in the effects that were observed in this meta-analysis. And again, as I've said a few times now, the need for innovative new ideas to be evaluated in our other two age groups is important. So just going back to what our overall considerations were as I started out with, right now we know that we can have a statistically significant positive impact on BMI around obesity prevention in our 6 to 12-year-olds, that it's a combination of physical activity and nutrition interventions together that is occurring in the education setting, and that it can be of both of short or long duration, and that we have consistency in our results across different research designs. And again, our final implications being that public health should promote and support these strategies amongst the 6 to 12-year-olds, that we need to continue our efforts in the education setting and focus on healthy eating and physical activity of those various durations while we keep on experimenting and learning what are effective in young children and adolescents, and very importantly that we work to really determine whether or not these impacts are seen over the long term. So 2, 3, 4, 5, 10 years into adulthood even, and whether or not that has significant impacts on chronic disease. So I'm going to stop there and see what questions or comments you have for these results. Okay, so one of the questions is, was there any evidence discovered regarding the access of fast food to schools? We're looking through the review right now, having just reread this again this morning. Nothing is jumping out at me right away that this was a specific focus of any one of the studies. There was an overall finding that creating access to healthier foods in schools is an important component of an obesity prevention strategy, but I don't believe that there was a study that really just focused on removing fast foods from schools and what impact that has. But definitely really important issue that we would want to be looking at as well. So another question here is there what indication of the intensity of the program? What do we know about that? And that again is also an excellent question. One of the challenges in doing a meta-analysis, and particularly here when we're talking about for the 6 to 12-year-olds where we have 31 studies, is while we have some strong evidence now with an effect size and a confidence interval from all of those studies, one of the things we lose is being able to really talk concretely about what the intervention was and what the intensity is. So what we what I can tell you is that that intervention really varied considerably across those studies. We know from short duration to long duration, as well as in intensity. Some of those would have been changes that were made that resulted in changes to the curriculum daily. Sometimes it was weekly, sometimes it was a number of sessions that occurred over an entire school year. So there's really quite a variation in terms of what the exact intervention is. And what's really difficult to do would be to then further break that down and do separate meta-analyses of all of those different combinations of interventions. So I don't have an exact answer for you. The next step would be, if these findings are of importance, relevance to you, the next step for you would be to really take a much closer look at this review and then particular studies and to examine those interventions more closely. Okay, so there's a question here. Sorry, I just lost it. Okay, in the plot of the interventions from 6 to 12, it seemed only 8 of the interventions had a positive effect. Is this a concern in the meta-analysis? So I might just get Heather to take us back to that slide. Thank you. That's an excellent question. So we just go to the next one. So, okay, so as we can see here, so what we would want to be looking at here is horizontal lines that don't cross the line of no effect. And I would agree, I can see, if you could just point to them, Heather, there's 1, 2, I'll point to them, right? So right here, this one, oh, right here. Okay, so we'll just keep talking. So what you can see is, out of these 31 studies, many of them do cross the line of no effect, which is saying there was no difference from the intervention to control group. And we have only a small number, it looks like about 8, that actually have a statistically significant finding. So we have to start asking ourselves, why is this so? And should we be concerned about it? So yes, you are correct. We do need to be concerned about how different these results are. And the reviewers make a point of commenting on this, and I did comment on it earlier, that there is a fair amount of variation from study to study in terms of the findings. Another more technical way to say that is that there was significant heterogeneity across the results. And the authors, you will see that in this review, they do say that. And that heterogeneity, those differences weren't explained by where the intervention was implemented, so the setting, the type of intervention, so whether it was combined physical activity or nutrition, or if it was something alone, the different ages, whether or not it was randomized, or how long the intervention. So yes, there's reason to be concerned about the variation about that. One of the things that we do when we have a lot of variation from study to study is we use what's called a random effects model. So a random effects model is something we do in meta-analyses that takes into account this big amount of variation from study to study and gives us a more conservative estimate of effect. So it actually allows more of that difference, those differences from study to study, to be incorporated into that diamond. So it is one of the good things that we see having been done in this review, is that they have used that random effects model, giving us that more conservative effect. The other thing that we can look at, just the information that we get by just looking at the forest plot without even thinking about the numbers that are there, is that those lines, those horizontal lines that are quite wide, quite long, tell us that we have a relatively small study sample. So a number of those lines are fairly long, which is telling us that that study had didn't have very many students or children in the study, which then makes potentially makes it underpowered to see statistically significant findings. So that's something else that could be going on here in terms of a number of them that cross the line of no effect. However, you'll also see that many of those lines are also very, very small, which is telling us they actually have fairly large samples and that that they still didn't achieve that statistical significance. So it is why we need to be somewhat concerned about these findings. It is statistically significant, but there is still unexplained reason for why we have these differences across studies. So thank you. That was an excellent question. Okay. So a question's raised that perhaps we are focusing on the wrong thing, BMI. What we really want is for kids to be healthy and happy in the long term. Preventing chronic disease should be the goal with a health-positive approach. And I agree with you completely. And just to reiterate, this review did focus on other outcomes as well. They focused on healthy eating habits. They focused on rates of physical activity, time children engaged in physical activity, amount of time spent in sedentary behaviors. They also looked at self-esteem. So there were other outcome measures in this review. However, from outcome to outcome, there were, in many instances, very few studies that really looked at a number of those outcomes. And so we're left with saying, one study found a positive effect on, for example, eating more fruits and vegetables, or 2 studies or 5 studies found that. The review put much less focus on those findings, and really the most concrete, most objective outcome measure in this review was BMI. But I do agree with you that the whole answer isn't just around BMI. It's much more complex than that. Okay, so we have a couple of other questions here. So we've answered that. So first off, I just see an administrative question which was around the slides, and we will be posting these slides, and I'll talk to you in a moment about where those will be posted. But yes, you will have access, as well as an audio file from the webinar will also be available to you. So I have another question here that says, were most of the interventions based on education provided to the children, or were there any aimed at educating parents? Excellent question there as well. So the easy answer is yes, there were other interventions that were assessed. So for example, among 6 to 12-year-olds, there were some interventions that only occurred in the education setting. There were interventions that occurred in the education setting plus other settings, for example, in the home, out in the community, after-school programs. And then there are other interventions that occurred completely outside of the education setting. And what they found in this review was those interventions that occurred only in the education setting seemed to be associated with significant reductions in BMI. That when other interventions were included outside of the education setting, that those studies didn't find significant reductions in BMI. Which is an interesting finding. I think I would agree with where you're going there. Why are we seeing that? So that was for the 6 to 12-year-olds, where they found interventions are most promising when it's in the education setting alone. However, with the youngest of children, so those for under 5, engagement of parents outside of the school setting, so for example, outside of preschool, seemed to be what was the driver for statistically significant reductions in BMI in those children that are under 5. So I have another question. How will these results be shared with the Ministry of Health and Long-Term Care Healthy Kids panel, the panel to inform Ontario's childhood obesity prevention strategy? So that's an excellent question, and thank you for alerting us to this panel. And we can certainly be involved in ensuring that the chair of that panel is aware of these results. We'll be actively disseminating the summary. So a summary of this review has been written and will be also posted along with a PowerPoint for today, and will be actively distributed through Health Evidence, as well as even more broadly throughout the Cochrane community, as well as internationally, so we can ensure that this information is provided to that group. Thank you for your thoughts on that. Another question is, can you discuss the weighting of studies included in the 0 to 5 years? Keller 2009 looks like a large sample, but low weighting. So if we can just go back up to the next slide up, Kara. So yeah, so here we can see, and maybe we just take off the red. So I'm just looking for Keller here. So what we see here is that Keller actually has a fairly, on its own, has a fairly large report, a large statistically significant reduction in BMI, and small numbers here only represent well, okay, so these numbers are a little bit off here because the weight that is given is in the overall meta-analysis of all 37 studies where we combine the 0 to 5, 6 to 12, and the 13 to 18. So that was really, really observant for you to have picked that up. So while the weight given here is 1.5%, it's not 1.5% for the 0 to 5-year-olds. It's across all 37 studies. It was actually given a fairly limited weight. And the one thing that we could say here is, compared to other studies, just if we look at the two lines, the results of the two studies above Keller, so we can just click on those, Heather, you'll see that those confidence intervals are a lot smaller than Keller, which means that those studies, comparatively speaking, were larger and therefore would have had more weight. And we can see that. They're not a lot, weighted a lot more, but they are a bit. 2.3% for Fitzgibbon, and for Riley it's 2.5%. So while Kelly had a very big effect size, like in terms of statistically significant reduction in BMI, it's a moderately sized study, and as a result has less overall weight in the finding. I hope that answers your question. Okay, so I have a large comment here. I will read it because I don't think you can see it, right? Or others can't see this chat. Okay, so I'm just going to read it out so everyone can hear this. I have used a wonderful rapid review of the evidence produced by the Region of Peel Public Health, which was published August 2011, called Effective Public Health Interventions in the Prevention of Obesity in Children from Birth to 6 Years. Effective interventions require a multi-pronged approach: sustained physical activity, limited sedentary activity, healthy eating, active parental caregiver engagement, cultural sensitivity, and socioeconomic sensitivity. Agree with the misplaced focus on BMI. Even the smallest improvements in feeling, looking healthier can prompt an individual to continue to make positive changes in his and her lifestyle. I have seen evidence of this in my own young children. So thank you for that comment. And also, I would also make you aware that the Region of Peel Public Health, which has engaged in doing several rapid reviews over the last few years, I believe is also engaged in making their rapid reviews available to others. It would not be a meta-analysis that they've done. They would have looked at a number of reviews on this topic and then come up with some recommendations that are tailored to the Region of Peel. So if you were to go to their website, you would be able to, if not find those reviews, you would be able to find a person for whom you'd be able to access those from. Thanks for that comment. So another question here: since children grow variably in height and weight, how was this controlled for with BMI as the outcome? Another excellent question. So there were two ways in which BMI was assessed in these studies, and one was just looking generally at BMI and looking at changes in BMI. Many times what that results in is, as children age, what increase in BMI was seen between intervention and control. So in other words, we would expect BMI to increase as children age, but what was the relative increase in comparison from intervention to control? So in a number of instances, we saw BMI increase less in the intervention group than it did in the control group. So that was one measure there. The other way in which BMI is assessed is what they call a BMI Z score. And so they compare BMI to standardized BMI scores across various populations for standardized height and weight in different countries for different types of populations. And so you would be comparing what the WHO has identified as standardized height weight metrics for different populations of children around the world and comparing that to what you have in your sample. So there were different ways in which the studies in this review reported that. The authors in these meta-analyses are focusing on the BMI. Okay, so just a clarification question, here. So in the Keller 2009, is the total 49 mean the number of participants? And looking at this very quickly, I would say yes, that is what that means. 49 is the total for the experimental group, and in the control group we have 134. Okay, so just another question here. Were other influencers, including parents, included in any interventions in the school setting? I believe a number of those, some of those studies among the both the 6 to 12-year-olds and the 13 to 18-year-olds, some of those studies did include in the intervention. Interestingly, what I can also add there is we at Health Evidence also just recently completed a review that focused on school-based physical activity interventions and its effect on various measures of physical activity and biological measures. And we found similar results in that there isn't a clear indication of when you include parents in the intervention. Sometimes that led to positive effects, and other times it didn't. And there really isn't a good explanation yet from the evidence, the studies that are out there, why that is. So there is some consistency between this Waters review and the review that we have under review right now at Cochrane. So I'm just actually going through. There's been a lot of chat, which is excellent to see. I'm really happy to see there's so much interaction. And here's another really good question. Any information on sugar-sweetened beverages? Again, at the level of this very large meta-analysis, I don't recall seeing anything specifically stated about sweetened beverages available in the school setting. It's just summarized to a higher level to indicate that having healthier food choices available for children had a positive impact on BMI, in addition to other types of interventions. So I'm not able to give you a and in fact, another one of my staff, Lindsay, has been looking at it as well and is saying no, that there wasn't anything specifically stated in this review. It might be that it would require a much closer look at the individual studies to see if any one of those has specifically pulled that out. Again, what our problem might be is amongst those 31 studies, you might end up with only one or two that looked at that as one of many outcomes. Okay, and so it looks like we've answered all of the questions and issues. I'm just going to pose if there's any other final comments that you'd like to make. And we just have a couple of more polling questions for you. I'd like you to consider. The first one is, did you find this data on the review helpful? You could comment on that in the polling question. And then the last one is, were these findings new to you today? So I'm just going to give you a moment to actually fill that in for us. And it looks like for many of you, you did find the data helpful that was presented, and for many of you saying the findings were new to you, which is great. It's also really positive when the findings aren't new, because it means that you've been keeping up on the literature and you are aware of them. And to some extent, so this update is continuing to support what has been said previously in the literature. Except I think what we have here is some more convincing evidence than perhaps we've had previously about the positive impact on BMI. Keeping in mind that it's not the only thing that we should be focusing on. And I would just like to point out that we have a comment that says, thanks from Portugal, and we're really happy that you were able to join us today. Thanks very much. So just one more question. Our questions and response is going to be available. And so I'll just direct your attention now to a posting board. We will be posting the PowerPoint summary statement that's been written, as well as the audio tape of today will be posted at the URL that you see in front of you here. If you aren't a registered user, registered participant of healthevidence.ca, you can easily register. We just ask for a little bit of demographic information. You would then be provided with a username and password, and you would be able to access the posting board. So we hope that you will come visit us often. It would be wonderful to hear your thoughts and see some ongoing debate on this, and hopefully this will spark other discussions internally in your organization and with other colleagues. I also just will let you know that given there were many people that wanted to participate today, we're always worried about having too many people on the line in case that affects how the internet will work, so we always cap the number of people. So we will be rehosting this webinar again on May 31st. So if you have any colleagues that you think you would like to have join us, please let them know about that. So I will end there. I would like to thank you for your time today. It has been a pleasure having the opportunity to present these findings. It was a pleasure reading this review and thinking about its implications for policy and practice, and I hope that you will join us in future webinars over the coming year. So thank you very much, and have a nice afternoon or evening or morning, depending on where you are.